So we can start off with the first case, ma'am.
So this is a premenopausal lady, 52 years old. She presented to us with complaints of next slide, please. So she presented to us with complaints of lump in the right breast. She was diagnosed as oligometastatic disease, CT4A-N1-M1. She has significant family history and also she has history of fibrocystic disease, which was diagnosed in 2018. So the histopathology was ERPR strong positive, HER2, 2 IHC 2 plus and FISH negative, and Ki67 was 30 to 35%. So based on the findings, we decided to go ahead with neoadjuvant chemotherapy. She had received 4 cycles of dose-dense AC, followed by surgery. She underwent surgery and then she received 4 cycles of adjuvant dose-dense paclitaxel, YPT2, N3A, M1, and adjuvant RT, also followed by hormonal therapy and CDK4 inhibitor. She was put on palbociclib 75 mg as the patient was intolerant to 125 mg and on letrozole 2.5 mg along with Zobon. The patient was doing fairly well with the above treatment. In April 2026, we did an assessment scan in which there was a few FTG avid lymph nodes in the left supraclavicular node, mediastinal node, and also there was a few periportal and portocable but no non-FDG avid lymph nodes. The biopsy from the left supraclavicular lymph node was necrotizing granulomatous, and the radiological review also showed the mediastinal lymph nodes to be of infective origin rather than metastatic. So we did an NGS for that on her. Can you move the slide? It was actually a liquid biopsy. Yeah, so she had germline, HBOC, BRCA1 heterogeneous mutation, and the VAF was around 50%. So, and it was PIK3 and ESR1 negative. So, what we wanted to know was what is the opinion on repeating a BRCA, germline BRCA, and also given that the VAF is 50%, can we take this as a germline mutated disease because it is given as VUS in the report?
So there are 2 BRCA mutations, right?
Yes, sir.
2 BRCA mutations of almost similar VAFs.
Yeah.
Okay.
And they have given it as VUS. So we wanted to know whether should we go ahead take this as a positive result or should we do a repeat?
Both of them are looking like a missense mutation.
Okay.
And I think let us have a molecular pathologist ideas on this.
Yeah, over to either Dr. Arun sir or Pushpa ma'am. Probably if you can take this and then we will go on to Arun.
Sir, Dr. Pushpa Singh here.
Yeah, ma'am.
If you consider both the variants being VUS right now, and especially it is a somatic panel which is being done and VUS based on that. So definitely this cannot be considered as one of the germline or any decision to be taken here based on especially this is liquid biopsy again. So liquid biopsy, VAF being higher, again, that is one more question mark that generally even in tissue, even many of the times disease burden is more, we get higher VAF. So this cannot be considered to be germline on this report. But however, considering the family history and if the person is having right now BRCA mutation, both being VUS here, germline testing may show different result as far as this one is concerned. So germline testing I would recommend here.
Can we go to the mutations, both the mutation reports?
Yeah, but before we go, I think was the germline testing done? Because I thought you presented it as saying that a germline testing
was done.
Yes, it was done.
So the germline also showed a VUS, is that right?
No.
What is
no.
This report? Liquid biopsy report, sir.
That's
no,
what.
Sir. Germline mutation was negative. It was written.
No. Can you go back to the germline? I mean, like the report, the germline thing.
He had written the germline as BRCA VUS, I think.
Yes, sir.
Okay.
Yeah.
That's why
Germline HBOC is also VUS, identified
Can you show
BRCA1 gene.
the mutations of the BRCA mutations of the? Can you show the BRCA mutations? Exact BRCA mutations
just go
of
back to the
the.
prior slide. Just go back to the.
Yes, like this.
Yeah.
Can you just zoom it up?
Was she zooming in on the picture?
Yeah, no, we were able to see that. No, it's
Yeah,
fine.
yeah, fine. No.
These are additional biomarkers. Under the additional biomarkers that have been detected, you have
Okay.
BRCA mutations, which are frame shift.
So what's instant? No, that's not frame shift mutations.
No,
These are missense.
no, it has been mentioned as a frame shift. If you go back to
No,
the
no.
next page.
No, it's not frame shift.
Go to the next page, Jesse.
This is liquid biopsy, as she mentioned right now to me.
Ma'am, this one, the one which is uploaded is the liquid biopsy, but initially we had got a germline HBOC as well.
No.
In that,
See, this
it
mutation.
was also still BRCA1,
Hello.
and
See, I understand. See, I understand this. See, this mutation which is being shown, both of these mutations are missense mutations. These are just translocations. So basically, protein changes. Protein. I want the molecular pathologist to answer whether this.
Let's go to the next page. I'll explain. Just go to the next page. Go to the next page. It's been mentioned there.
These are complex mutations. These are.
Wait. Just come down. Scroll down. Just scroll down. I mean, even just go up a little bit. Okay. There it is. So it's mentioned that it is.
That's ARID1A. That's ARID1A is a prime shift mutation.
Correct. Let's scroll back and look at the BRCA1 mutation as well. They would have mentioned that.
Can you just show me the BRCA mutations, please?
But anyway, in the meantime, we always know that a VUS is not actionable. So there are no therapeutic implications for a VUS. We do not act on VUSs. As far as the germline sequencing is concerned, given the strong family history, definitely yes. And then you could look at doing a segregation analysis and then doing a cascade testing given the family history. Look at it whether it's on the maternal side or the paternal side. You can do a segregation analysis and then look at doing testing the other family members for the same VUS. And if so, then you can get it reported on the India Cancer Genome Atlas. Just like how the TCGS, we now have Indian Cancer Genome Atlas. So you can get the VUS reported and then follow it up after 6 months or periodically. See, because about 10% chance that a VUS, today's VUS can become a tomorrow's potential pathogenic or likely pathogenic variant. So that is also something that
I would like to throw some light on this. See, I just want to ask the presenter whether those VUS are the same mutations as this in the liquid biopsy.
Yes, sir. In the germline also, it was reported as VUS only.
No. See, was it the same mutation as that of what is seen in this?
The same BRCA variants he is asking.
Yeah, I got it, ma'am. Just a minute, because we don't have that report. We just have written copies. I'll just go back to it and I'll let you know. 2 minutes, ma'am.
Is there any, have you done a MLPA in the germline along?
No, sir.
So was in silico modeling done?
That I'm not very much aware, sir.
I think Juno must answer that. So see, there are two mutations which are like missense mutations. So the BRCA protein may behave differently when you have two missense mutations. Okay. Actually, there must be an in silico modeling done for this BRCA protein with these two different mutations together, and then see whether the protein is getting truncated. And then only we can really say whether this is a significant mutation. See, it may be if germline is showing the same VUS, and this is also same VUS, I would consider this as a pathogenic mutation and report it to the genome atlas. And then accordingly, I will consider going with olaparib. Okay, this is what I would do if it is my patient. Okay.
Okay, fine. But JC, sorry to interrupt you. I think as of right now, if the lab is, if they would have cross-reference with either the ClinVar or the other databases or the OncoKB or any of the other databases, if it is still put down only as a VUS, it's very clear. I think the message for all the postgraduates and everyone else is do not act on a VUS. Only if it is pathogenic or even likely pathogenic, then you act on it. And for that, you will have to get it reported to the genome atlas, and then only if it becomes a pathogenic or likely pathogenic, then you otherwise it's not
See,
actionable.
I say that happens. See,
Therapeutic.
these two mutations separately could be a VUS. Together, together could become a pathogenic. So it may not have been reported as on date, but it may become a pathogenic mutation down the
Exactly.
line.
Exactly. So
Down
we'll
the
have to wait
line.
until then. We'll have to wait
So
until then. I don't think
that's why I would like, when there's a strong family history in the background and you have a liquid biopsy showing the same mutations and the germline showing mutations, you have a clinical variant sitting there. So I would think about giving the treatment, but I would explain the patient. I understand that postgraduates are here, but this is something which postgraduates needs to understand if you all put it in the clinical background. But this may not be a right indication, but this may become a pathogenic mutation in the later line.
Again, just to put a perspective to it and to add numbers, if you talk about VUS becoming pathogenic, there's about a 10% chance, number one. And number two, if you want to talk about family history, then you should do a segregation analysis. You should test the other family members, see if they have the same VUS. And only then it becomes, because the others may not have the same VUS.
Absolutely, you can go ahead and test the family.
So I think for all of that, the patient has to first undergo genetic counseling and talk to them about pre-test counseling, post-test counseling. Tell all the
boss, I think the patient already had a genetic counseling and genetic germline testing.
I'm talking about testing the family members as well.
Family members.
First of all, you need to segregate that, get a family history, check whether it's on the maternal side or the paternal side, do all of that. As of right now,
who are the family members affected? Family history-wise?
Family history-wise, she has grandmother and maternal aunt, maternal uncle, all of them were being diagnosed with
you can test the maternal side first. The genetic counseling on the maternal side there first. I think Kripa's argument makes a sense in this, okay? So if you find the same mutations in the maternal side, I think we can consider this as a pathogenic, okay?
Okay.
Even then, you get it reported, and then anyway, I'll probably bring in Dr. Pushpa ma'am here. Dr. Pushpa ma'am, your thoughts on
yes, sir.
biallelic loss and homozygous, heterozygous, all of that, and all these, both the BRCA mutations as well, ma'am.
Yes, sir. Here, if you see, there are two variants again.
Right.
Biallelic loss is can be suspected, but only thing is, as you said, right? I think we have to do a cascade testing in the family members there. If it comes positive, I think we have to report. As well as there is other thing. Suppose in case I am taking it as the other part of this one also. Suppose if family members also are checked and they come negative.
That's right.
Then we have to go back to the lab and insist them on having a follow-up after 3 or 6 months again to understand whether these variants are reclassified as likely pathogenic somewhere after that. And the other thing what we have to do is, I think HPOC panel has been done here.
Only if you report this, there's a likelihood that it may be classified. If you just keep on checking the variant, it won't be classified.
We need to report.
That's right.
I think lab.
So I think we have a consensus there as far as getting it reported, yes. As far as doing a cascade testing, yes, and a segregation analysis starting with the maternal side. I think that's the consensus here. And as far as acting on it, therapeutic implications for a VUS, not right now. You may do it. Absolutely. That's right, ma'am. Absolutely. No point in doing it now. Probably what JC is trying to tell you is that, when you run out of options, you've exhausted all your standard of care options, and you really don't have anything much to go back and fall back on. It's probably when like desperate times call for desperate measures. Then you would probably look at using platinum or PARP inhibitors if you run out of all options. Otherwise, as of right now, this has got no therapeutic implications. Like we spoke about earlier, do a genetic counseling and also offer cascade testing and segregation analysis on the maternal side, and see if, and also definitely get it reported, see if it can become pathogenic or likely pathogenic, follow up 6 months later to check on the state.
So, sir, right now, sorry, I don't have the information on whether the HBOC, the mutation which was there on the germline, is similar to the one which is there on the liquid biopsy. If at all they are of the same variants, what would be the next step that we would be doing?
Family screening, maternal side screening, just call the maternal screening and just get it done. I would see if the maternal side screening is also showing the same mutations as that of the patient, then report it and then consider it as likely pathogenic. Okay.
Yeah.
And
See, I think
also,
Okay.
and also one more suggestion, just a suggestion, ma'am.
yeah,
If you don't get the genetic report, just check whether they have checked only for BRCA1 and BRCA2. If they have done, or they have done a comprehensive genome germline testing. Because again, the chances, suppose if these two variants are no absent or negative there also, or VUS there, and any possibility of other variant, germline variant to be positive, we should check. Sir, your opinion on that, sir?
correct, ma'am. Absolutely. I think, as far as the germline VUS is concerned, we know these are all incompletely penetrant genes. They don't have 100% penetrance, number one. And even if they do, then the expression varies. They don't always have 100% expression. See, the reason why I'm talking about this is, not everyone with a BRCA1 mutation will 100% go on to manifest with disease. And the same vice versa as well. Which is why, we will have to look at training.
But this mutation has manifested as a cancer here.
Exactly, but if the other family members, like for example, when you screen them,
If
and
the other family, as you said, if the other family members are not having this mutation,
exactly,
then I accept. If this
exactly,
mutation is going to be in the same family member,
no,
even though
exactly.
it has not been reported as a highly penetrant gene,
No,
we should
Jesse,
consider this.
no, that's right, Jesse. Relax. So the thing is, that's why I'm saying, without checking the other family members, we can't jump to conclusions and say this is pathogenic or likely pathogenic. It's not right for us to say that when the lab has classified it as a VUS, and it's not right to act on a VUS. It's got no therapeutic implications. And I
And
think that's the
even if the cascade testing is positive here, sir, in the family members, we are just reporting it
exactly.
again, and that no action can be taken right now unless
It gets
some
reclassified.
other cases. Yes, it has to get reclassified.
Okay.
Correct.
So now we would go ahead with segregation analysis, cascade testing, counseling for the family members.
So
Based on the output of that, we will take a decision, is it?
That's right.
If possible, repeat the germline testing, comprehensive germline testing for the patient, ma'am. That will be
Okay, ma'am.
like
That
at least
was
you will have
my
a
other
report in hand.
question. Okay,
Yes,
ma'am. Repeat one more germline testing, is
yes,
it?
ma'am.
If the patient
Okay, ma'am.
has report already in hand, no need to repeat, no, ma'am. Why to repeat?
I don't think report she has, sir.
What we have is the one which is documented, ma'am, a long time. We don't have the printed report. So we
Exactly.
wanted to know, based on this, first, should we do a repeat germline testing and then, act upon the VUS
No, I think,
based on the results of it?
no,
you
please go
already
back
have
to
a
the
you already have a report of the germline, right?
yeah.
Yeah,
Why
that
should
was
you
the
go on the
initial
So
one.
please
Yes.
go back
why
and collect that report and see,
Okay.
check on the report and just
Okay.
tell us whether it's the same or not. Just
Yes,
do
sir.
that first,
Okay. Yes,
and
sir.
then
I'll
probably
get it done.
we
Yeah.
can go ahead. Not right to assume anything.
Okay, sir. By next week, maybe I'll come back and I'll update on that one.
Sure.
Yeah.
Perfect.
Yeah.
Sir,
Thank you, sir. Thank you so much.
sir,
Thank
is
you,
there
ma'am.
any point in doing an MLPA for this germline testing if it's not done?
Yeah, definitely. I think, that really does make sense, Ashwin. I think, even though a lot of times right now they say with the third generation NGSs that, MLPA doesn't add much, but you're right, absolutely right in that. An MLP or a multiplex ligation dependent probe assay would definitely help us pick up large genomic rearrangements like deletion and insertions. So yes, the gold standard would definitely be to do an NGS with an MLPA. I'm assuming that the germline would have been done that way, which is why they'll have to probably clarify with the lab and get back to us with the printed report, where we can clarify all of this.
Yes, sir. Yes, I'll do that.
So can we have Arun sir's comment before going to next,
Yeah,
please?
I'm missing Arun, sir.
Hi, sir.
Hi, sir.
Sorry, I just wanted to pitch in also. Very great points, plus one to everything. But I also want to add on one another point. If there is an urge to act upon this variant immediately, please do a HRD testing. Okay, so if the tissue block is available, that could also give you a clue if this is the driver in this tumor. Secondly, it's not uncommon to see two VUS in the BRCA gene in a patient, which could be a simple polymorphism. Just because we haven't screened the Indian population so much, we need not have picked it up. So just because you see two BRCA mutations does not need that both of it could be pathogenic. We should really look into the functional aspects of it before taking a call on the pathogenicity of it. So definitely cascade testing, reporting to the database, and waiting to watch if somebody does a functional assay and taking a decision on that would help. But as of now, if it is to do with the patient's therapeutic options, I would strongly suggest doing a HRDSA. Thank you.
Okay, sir. Yeah. Sure, sir. I'll go back and look into the the original report, and then by next week we will represent this case. Thank you so much.
Yeah.
Hello.
Probably you can summarize. Narendra or Chandrlekha, we can summarize and move on.
I've joined in between, sir, so I'm not
Okay. So
getting.
Chandrlekha is around. Summarize and then we can move on.
Okay. Should I start presenting, sir?
Yeah, it's okay. Go ahead, Nadeem. Sorry. Go ahead, please.
Yeah. Hello, everyone. I'm Dr. Mohammad Nadeem Ahmed. I'm a consultant medical oncologist in Hyderabad. So I'll be presenting a case. Actually, she is a non-cancer person. She came to me with with the following test. I'll just give me a second. Yeah. So she has her mother, who was she's 25-year-old female, recently married, healthy, asymptomatic. Her mother was diagnosed with CA breast, and she expired 3-4 years back. And her maternal grandfather was diagnosed with brain tumor. He also expired long back, no details. Currently living, her maternal half aunt, diagnosed with breast cancer, found to carry a also was tested and was found to carry a pathogenic germline TP53 mutation. So we got her tested, the patient, the subject, 25-year-old female, Fatima. So we did NGS hereditary cancer gene panel for her, in which she was detected to have the TP53 mutation along with the missense mutation in ATM. These two things. So she wanted, she came to ask how.
Can you go to the report?
Yeah,
Can you
yeah.
move the slide and go to the report?
Next slide. Yeah.
I think in next page it is clear. Third page. Go up again. No.
No,
This is
next
the report of the
page.
There
patient.
has
This
been
is the report
clearly
of the
variant
patient.
description also in some page that
There
I
is,
want.
there. Please move on to the next slide. Next slide, like that. You keep on going.
Yeah.
Yeah.
Okay, that initial report was whose report? The previous
Same.
report.
No, both are.
This is one report, another one report previously it's shown, no? That is
The one which was not having any mutations. Are you asking that?
Correct.
yeah.
That was her sister's. I
Okay.
have to tell further history once we go through this report. This is
Okay.
patient Fatima, not patient, whatever. Her report.
So your question, sir? Your question for this tumor?
So actually I wanted to discuss because she has TP53 mutation in her.
You can complete your history as well. Complete
Okay.
the history.
So she has TP53 mutation. The subject, then her mother, we couldn't test. She expired 4 years back, breast cancer, and then her maternal aunt, who's alive, also has same variant of TP53 mutation. Now she has 3 siblings. Now, out of those 3 siblings, herself and her sister, who are of the same age, got tested. Her sister is negative and she is positive. Other 2 are very young. One is 12, another one is 15. They are not tested yet. Now, this is Li Fraumeni syndrome. So I wanted to just discuss how do we plan her screening protocols, and also she's marrying her cousin. Well, she got married already to her cousin. So now she wanted to ask about screening for her and for her younger sisters, and whether she can have children when, and all those things, sir. Just I wanted to discuss the case.
So we'll start with Arun sir and Pushpa ma'am's views, and then we'll take it forward.
Arun sir, will you pitch first?
So, ma'am, I mean, this seems to be a very clear Li Fraumeni. The TT53 that was seen is definitely a quite a pathogenic variant, and that is correlating with the family history too. I think what we need to just see, and I won't look into that ATM variant as of now because it's a VUS, and ATM is notoriously known to have many such VUSs without any clarity on whether it's going to be pathogenic or not. So, as of now, this seems to be a good a case of Li Fraumeni. I think I have heard many times Dr. Kripa talk about the management and classification of Li Fraumeni
Yes,
and all that.
yes.
So always,
I second that.
yeah, I want to hear that again.
True, sir, true. For exactly that only I'm present.
So so nothing. So I think like all of you have agreed to, this is the SBLA syndrome, sarcoma, breast leukemia, adenocortical carcinoma. The COMPRED criteria is fulfilled. But as far as the patient who doesn't, patient's relative. I mean, I think the sister you said who's negative, right, for the people.
Yes.
So she doesn't have to go through the rigorous screening protocol because she doesn't. I mean, like, she's not a P53 mutant. She doesn't have the pathogenic mutation, right?
No.
So this patient, yes, she needs to be screened, as in par with the COMPRED criteria, and the regular. We could go with the regular screening criteria for the breast leukemia, adenocortical carcinoma, and sarcomas. So I think here this is very classically Li Fraumeni. I mean, like, we're talking about somebody with a Li Fraumeni here. So it's a regular screening protocol for the others, but not
Screening.
Yeah, screening
For breast and
yeah, colon as well.
also colon, and then CBP every yearly, sir.
Correct. That would be ideal. That would be ideal for her. We've got to start. I mean, like, how old is she? I'm sorry, I forgot that.
25, sir.
So that'd be about the right age to actually start screening her for the other malignancies as well. Hello?
So, sir,
Yeah.
from my side, there is a website called as Gentur, ER and Genturis, if you people are aware. It is basically Genetic Risk Tumor Syndrome Network. It's a European reference network. So, if you go to that website, there is a clear-cut, the guidelines on what do the further risk screening should be done for basically the Li Fraumeni syndrome. I can share that in the group once this is done. And one more thing, since she is planning for the pregnancy, coming to that, so generally in prenatal testing, what we do is any lady who is asymptomatic but still carries a heterozygous copy of the variant and probably showing a risk, she has to undergo the husband. Actually, if the husband is from the same family, generally we ask the husband also to undergo the screening.
Husband is her father's brother's son.
Yeah, so consanguinity is there. So husband also need to be tested. If generally the guidelines for prenatal, whenever they go for a pregnancy planning, if they go to a geneticist, this is generally done. So once they both are screened, so planning pregnancy, either they recommend every pregnancy, natural pregnancy they plan to undergo either CVS or in the third month or fifth month, or third month CVS, or fifth month, after fifth month generally amniocentesis, where the fetal this one will be taken and that will be tested for the same variant which is present in parents. And if
Okay.
that comes positive, they have to decide what to do further, or plan an IVF with the embryo testing. Generally, this is how. If both the parents are positive, if one is positive, then it should be a donor ovum or sperm. Depend on that. So this is how the prenatal screening goes.
Is IVF with embryo testing acceptable as of now?
Yes, sir. They are doing.
Okay.
I was in Mediscans and we used to do this. Actually, we used to send for IVF testing. So during IVF, the each embryo is tested.
Okay. Sure. Okay.
You're right. I can vouch for that as well, ma'am. I mean, like my wife's infant specialist, so they do that a lot. I agreed with you.
Yes, sir.
That.
They are doing this because I was practicing this for almost one year there.
And also, there's a specific site which looks at only the type of P53 mutations and classifies that online. It's called My Cancer Genome P53 Atlas as well. So we could look at that as well. And also, the routine screening protocols, you could either follow the Toronto protocol or the NCCN surveillance protocol, whichever works for your patient. But there's a body even recommends a whole body MRI screening for these patients as well, starting
Yes,
at 20.
the genetic counselor recommended whole body MRI. And also testing for her two siblings who are not tested.
Yeah, so I think, if resources are not a constraint, if they have access to all of that, yes, you can even do that. But otherwise, even the regular, screening protocol that we would do, breast, colon, all of that, even that's also absolutely fair enough.
How frequently can we plan a whole body MRI, sir?
1 year, yearly.
Oh.
That's the recommendation.
And also MRI brain also they recommend yearly ones.
Correct, absolutely. So when you're doing a whole body MRI, it includes the MRI of the brain as well.
Okay.
Does the father require the screening because looks like the maternal side is only affected?
Has the father been screened? I mean, like, have you got?
No, not screened.
No.
Not screened. Father is from paternal side. Father is
the husband.
patient.
I mean the husband. Does he require screening? Because
husband is the person's
side.
father side.
Yeah, so
Person's
but your
father's brother's son.
Okay.
Yeah.
We can't do much about the consanguinity, but yeah.
A lot of consanguinity.
No, they actually they got married, but I mean they are not together. I mean there's that Ruksati, what do you call?
No,
that didn't happen yet.
Okay, get it.
They are very doubtful as to go forward with this everything. Discussing that.
I wanted to share one experience regarding the same aspect. There was one patient, like
Hi, Jaren.
Yes, Jaren. Go ahead, Jaren.
I had a family of 4 members with Li Fraumeni here. So this annual MRI is easier said than done. It is a huge headache because each lump is very difficult to convince for to do a biopsy, not to do, how to go about it. And one among those family members was actually undergoing infertility treatment when it was detected. The Li Fraumeni was picked up in the family. So they finally decided to go ahead with the usage of a donor ovum. And they were like, no, I don't want to take the risk, like both the husband and wife together. And I just want to share that this happened just some few months back.
No, absolutely. I think, see, the problem is when you don't, I mean, like you rightly said, there are challenges to doing a whole body MRI in India. But I think, it's an option that needs to be discussed. There are plenty of centers, like, for example, Hyderabad, Mumbai, all of them where they have access to even PET MR or even whole body MR as well. And, I'm sure most of us would have read it in the paper as well as the, the sperm donor who once, had a P53 mutation and ended up passing it on to.
Yes, I had this experience.
Exactly. So, I think those are all, they're all making headlines and catching our eyes as well. Yeah, we've definitely got to look at screening for that.
Okay.
Yeah. So I think we'll summarize, Nadeem. And
yes.
Okay,
one more just query I had. Now, I think siblings, they told one was 12 and another one was a smaller one yet. So, if we look into the guidelines, generally 18 above only germline testing is required.
Not necessarily.
Yes. So
Not
basically, for
necessarily.
these kind of patients, we can test.
Only for BRCA1, BRCA2, it is 18 years. Otherwise, it is not 18 years. There are medullary thyroid syndromes and all, you can screen even at the age of 2 or 3. So that is different.
And that to Li Fraumeni,
Yeah.
Leave from any
Leave from any, you can test as early as possible.
Okay, sir. Got it. Got
I
it, sir.
think the siblings also might have to require this ultrasound because this adenocortical cancer is seen like at a younger age, like maybe less than 18 years. Like,
Yes.
Can we ethically suggest them not to have a consanguineous marriage if if they come up with that
no,
question?
what I meant, I think it got misinterpreted. The thing is, what I was telling is, her husband is
Not about
actually
like
not from the like a husband is not from the mother's side, right? A husband is from the father's side. So
yes,
your history, your document, everything is the mother's side is only affected.
yes,
So I
yes.
don't know. I don't think maybe he's going to be affected or not. So I don't know what is the logic in testing him. That's what I was trying to raise.
Before having pregnancy, before conceiving, we just want to make sure that that doesn't
It
being
is always
affected.
mandatory, sir. Whenever a couple goes for a screening, whether the husband belongs to the same family or other family, husband is tested. Couple are tested together always. Because he may not be positive for the same, but some other things may come up. So generally, they are not taking risk in most of the clinics.
The problem is, ma'am, it leads to a lot of ethical dilemma because there are
Yeah.
some people who abandon the wife once they, like a lot of issues there because they're. I mean, there was one patient where as soon as he found his wife was having some problem, he just abandoned. So there are a lot of ethical dilemma related with it. So I don't know.
Yeah, but then Ashwin, like ma'am was rightly saying, vice versa as well. Once you figure out something after the pregnancy as well, that's bound to become worse. Like the case with the sperm donor, and who's already donated to 100 children so far. So I think it works both ways. So it's again got to be
Again, it has to go with counseling, sir. It has to go with counseling.
absolutely. It has got to be
Yeah.
counseling and then shared decision making where they're also made to understand.
Okay, sir. So we'll quickly summarize this case. So we have to, as of this case, is a classical Li Fraumeni prevailing in this family. So we have to look into three issues. Right now, the lady who is 25 years who is carrying the gene has to be rigorously screened with an annual MRI and and the second thing has to be screened as well right now itself. And the third thing is he has to be counseled regarding the offsprings of this affected lady subsequently, and whether they can consider any IVF procedures, and the proper genetic counseling needs to be done for this lady for the subsequent offsprings. Yes, sir. We'll move on to the next case.
Then ATM VUS is not significant. Yeah.
Yes, yes, sir. Okay, okay. Dr. Jarin, sir, you can carry on.
Can you go to the next slide?
Yes, yes.
So this is a 35-year-old male. He initially had in last September basically a presacral lesion, which was operated by a neurosurgeon, which was basically an R1 resection. It turned out to be a malignant peripheral nerve sheath tumor. Within say 1.5 months, patient had a recurrence again. This time he underwent complete resection R0 with local lymph nodes are also resected off. The histology was the same, malignant peripheral nerve sheath tumor. But since it was a recurrence, after discussing, I think patient underwent RT, and following that, patient came to me, and within 2 months of completing RT, he had developed abdominal wall mets. There was some peritoneal disease and extensive disease, basically lung mets and all. So we started with palliative chemotherapy. Peripheral nerve sheath in general, the response is poor. So we started with IA anyway after explaining all that. And we had done a CGP for this patient also. So I think we have the report, the next page. And two cycles of IA, the response is inadequate. After seeing this report, I have actually changed over to VAC. Just wanted the panel's opinion on because the BCOR mutation was picked up. And also the HRD score is also high. So what is the optimal regimen? I have started with VAC. And what is the role of like PARP inhibitor? Is there any role for this post chemo as a maintenance or something? Or is there any other better option? Because the response seems to be overall poor here clinically.
Can you go to that NGS? Can you go to the final report?
So here the MSI is stable. HRD was positive with a score of 51. And lower down, can you just go down a bit? Yeah. There was a BCOR which was picked up. So is this like a BCOR mutated sarcoma? How often do we get that in a malignant peripheral nerve sheath kind of phenotype?
There is also a KRAS mutation,
Yes.
which seems to be an activating mutation as well, the high VUS. So any history of neurofibroma that this patient has got?
No, nothing.
No enough.
No, sir.
Anyway, we'll get Arun sir's and Pushpa ma'am's views on this, on the NGS before we proceed.
Sir, I mean,
Arun
this,
sir, you want to go?
yes, ma'am, yes. So, see, the main clone seems to be the KRAS and the BCOR mutation because both the allele frequencies are quite similar to each other. So I would say that is the main driver clone, followed by the CDK12. The HRD positivity could be driven because of the CDK12 mutation, probably. But therapeutically, I don't know. I don't think any of this is maybe MEK inhibition for KRAS at best.
Yeah.
But whether that's applicable for this tumor, I'm not sure.
Yeah.
So as far
Was there
as
any amplifications in this? I think I saw some amplifications. Was it there in this? Any amplification?
Can you
Or
go?
was that a different report? Can you just go up, please?
Yeah. The next page.
Yeah. No, next page.
Next page. Scroll down. Yeah.
Okay.
no, that
In
must
this
be
case, there
different.
is a fusion you see here. EWSR1 NF2 fusion
Correct.
of uncertain significance was detected. So this is a
Family of tumors.
of uncertain significance. Yeah. So that is something if can also give you a clue towards the histopathology of the tumor. But unfortunately, therapeutic wise, I don't think targeted therapy is a direct option here.
That's right. So again, Jaren, see, had this, had you given me a history of NF1, I would have said probably transformed MPNST from neurofibroma. And we know MEK inhibitors are approved for plexiform neurofibromas, which are inoperable or unresectable. We have a couple of them that are already approved. One is selumetinib, the other is mirdametinib, based on the Renu trial. So I think here, probably you could say this is probably a BCOR-driven or SIK-driven, all those aggressive sarcomas, Ewing's family of tumors or Ewing's-like sarcomas, as we would classify them. So very aggressive, poor prognosis, no matter what you do. So I think, what have you planned for in the second line?
So actually, it's not a second line. It's stable, but not much response. So from IE, I switched over to VAC-IE. I'm planning like VAC-IE, like how we give for Ewing's and we'll see kind of situation.
So because, I think one of the fusions that's been picked up, and that was rightly mentioned as well, is the AWSR NF2 fusion that's been picked up as well. So I think we could go ahead and treat it along the lines of Ewing's like sarcomas with VAC-IE. I think that's definitely agreeable for sure. I don't think as of such there's anything much which you can act on. The HRD, remember, it's not yet standardized for sarcomas.
HRD can be HRD and CDK12 considering the positive as Arun sir said. I think this can be an off-label option we can keep as. And other thing I just wanted to check, have they done RNA fusions also or here sir, in this test?
I think yes, but
Was an RNA sequencing done?
Yeah.
Yes, obviously it is done because then only they have done fusions here. EWSR.
No.
EWSR can be identified by DNA
DNA
also.
also.
Exactly.
Well, then you have to go to the next page and see
Yeah,
What are
exactly.
the
No,
fusions
no. I
tested?
have gone through the report, but there is no mention of RNA sequencing here, sir.
Exactly. So I think we need to check on that. Check,
Yes.
Jaren, of whether RNA sequencing was also done.
I will check on that, sir, once. Sure.
RNA fusions. But anyway, I think,
Can you go to the last page of the report? Last page. It's only DNA, I think so, probably then.
Yeah.
So yeah. So I think worthwhile.
RNA sequencing may be needed here, sir.
Definitely agreed, ma'am. I think you can definitely look at getting an RNA
There is
sequencing.
some finance issues here, so I have to limit myself also.
I think whenever we're doing a sarcoma for the sending, it's very important to send the RNA sequences because most of them are fusions which is presented. When we are sending only DNA, I don't think so. It is going to be worthy.
In case of RNA splice site fusions and all, it cannot be identified here, sir. So we may have chances to miss many fusions here.
Correct. I think definitely yes. RNA sequencing is definitely. I mean, like you can get it offered. I mean, like probably if at the time you're done a DNA sequencing, you could have asked the lab if they could do both DNA plus RNA sequencing, because the same lab does both DNA plus RNA sequencing as well, at a marginal additional cost. So I think that could definitely be looked at. You can talk.
I didn't think the CGP panel. Is it a blood panel or the most of the CGP panels has RNA and DNA?
No, but I think we've got to ask for it
No.
particularly. You have to ask
You have to check, sir. Not all companies do that.
That's right. So we have to ask for it. But anyway, I think from a therapeutic point of view, I think, Jaren, there's absolutely no reason for us to act on any of these. None of these are actionable mutations. Probably if you've exhausted all your standard of care options and getting really desperate, you can try MEK inhibitors, off-label indication later on. Or even MEK plus, like Arun says, favorite, CDK4/6 plus MEK inhibitors also. Like there is a very early data, phase 2 data as well on that. So, but all of that is experimental off-label only when you've exhausted all your standard of care options. As of right now, you're justified in treating this like an Ewing's-like tumor or Ewing's-like family of tumors or Ewing's-like sarcoma. So VAC-IE, yes, if you've already chosen to go with it. And you said also the patient's got a stable disease to VAC. So fair enough, I think you can go with VAC-IE and then let us know how the patient responds.
Sure, sir, sure. Thank you.
But it's definitely an aggressive biology and very poor prognosis, given that it's BCOR-associated sarcomas.
Thank
Yeah.
Okay. So to summarize, this gentleman who has a BCOR-driven sarcoma, as such the prognosis is going to be an aggressive one. And here we have other non-actionable mutations which are present. So in case we need to use it subsequently as an off-label, we can use it subsequently. Otherwise, as of now, since it is a stable disease with VAC-IE, to proceed with VAC-IE as of now.
And get an RNA sequencing done. So.
And an RNA sequencing, yes, sir. And definitely an RNA sequencing and to be asked for. So over to Dr. Rajiv Gandhi for the next case presentation, sir.
Yes, madam, I'm here. Shall I start the case, madam?
Yes, sir.
Yeah. From my side, there is one 53-year-old male patient who was diagnosed with incidentally detected gallbladder carcinoma. Patient was initially operated for cholecystitis and incidentally found to have gallbladder carcinoma. In that, simple cholecystectomy was done, and that cystic duct margin was positive post-operatively. And the patient was advised a radical chole, but they were not willing for immediate surgery. So the patient came to me, and I've started. The patient was HbA positive patient, and I started the patient on gemcitabine cisplatin. Initially, 4 cycles have given, and after that, patient was advised surgery, but they again defaulted for around 3 to 4 months, and presented with obstructive jaundice to us. At that time, we have done re-imaging was done, and ERCP stenting was also done for obstructive jaundice, and multiple omental nodules were noted on that time, and biopsy was taken from that, and NGS was sent from that biopsy specimen, madam. So I have attached the NGS report of that omental biopsy, and shall we move to that NGS report? Yeah. This is the CGP report what we have sent during the recurrence from the omental biopsy. In that, TMB is low, and the MSI is low, and the HRD is negative, along with the TP53 mutation was there. And we have seen HER2 missense mutation was there, with a VAF of 46%. And ASXL VAF of 3.4 was also noted, and HER2 copy number variation was also there.
What is
And
the copy number?
5,
It was
sir.
5, sir.
5, sir. Exactly, yes, sir. And after that, we have started the patient, based upon this, we have started the patient on capecitabine, oxaliplatin, along with pembrolizumab. After 6 cycles, partial response was noted. So, in the lieu of maintenance, we have shifted to capecitabine plus pembrolizumab. Another 6 cycles we have given. Later, patient again developed obstructive jaundice now. And in that, initially, we have sent IHC also for HER2 testing, which was negative, 0, IHC is 0. So, based upon this report, can we start any anti-HER2 therapy for the patient? Go to the tumor board. My questions are, what will be the ideal anti-HER2 therapy for this patient if we are going to use the NGS report for further therapeutic implication?
Sure. We'll get to your therapeutic questions a bit later, but first we'll get our molecular experts, both Dr. Arun sir and Pushpa Singh ma'am, to comment on the NGS report, and then we'll get on to the therapeutic part of it. Sir and Arun sir.
Yes, sir. So this is, I checked the mutation specifically. It is a pathogenic HER2 mutation. And the copy number 5 is just within the standard deviation of an NGS detection limit. Maybe it will be 1 plus or 2 plus in the IHC. So definitely this is targetable, and the copy number, the VAF of the HER2 is also very high, like 46%, 47%. So this seems to be the driver in this case. Interestingly, this is a point mutation and not a amplification driven HER2 pathogenesis. So therapeutic, I mean, you can definitely check. But TDXC would be one of the options for this, because there is both an amplification as well as a point mutation. TKIs can also be there, but I don't know if the advanced TKIs for HER2 is available in India. That's I would request the medical oncologist to discuss on that. Yes, thank you.
So I think
As far
yeah.
as ASXL mutation is concerned here, that is also 3.4%. So should we, and as far as therapeutic, this does not concern anything, sir. But its VAF is also low. So that can be just ignored. But TP53 again is there. So Krupa sir, Arun sir, do you suggest for HER2 as a therapy directly or any combination because of TP53 here?
I think, ma'am, irrespective of the TP53, HER2, especially in gallbladder or biliary tract cancers, the current approval is as tumor agnostic therapy is only for IHC 3+. So if you've exhausted all of our standard of care options, and if the patient is still progressing HER2 mutations, we can extrapolate the data from basically lung and say TP has got an option.
Yeah. I have a small take on this again. See, Vasisumab deruxtecan, you require some anti-HER2 to be expressed on the tumor cells, so that it is engaging with the tumor cells and then getting into the deruxtecan into the cells. So without any expression by IHC, not even 0+, it is not going to work. I understand that it's lung cancer, wherein HER2 mutation is also approved, but in this case, probably only 3+ or any expression showing there on the IHC would be an ideal case for giving trastuzumab deruxtecan.
Correct. Absolutely no denying that. In fact, that's the point that I was trying to make as well. As far as a tumor agnostic indication, the current approval across pan-tumor indication, the Destiny pan-tumor O2, is for HER2 IHC 3+. 2+ was also included in the trial. And this patient's IHC report, was it 0, 1+? What was it?
0, sir.
It was 0. Fine.
Yes.
So in that case, if you, like I said, if you've exhausted all your standard of care options, if you've progressed on all available standard of care lines of therapy, then you can obviously take an informed decision making with the patient and tell them, because you have a HER2 mutation, and this is a drug that's been approved in other malignancies for HER2 mutation, I can offer this as an off-label indication once your patient has progressed. But what's interesting is why did you look at probably adding IO in the second line? Your first line, what did you give in the first line was gem and platinum, right?
Yes, sir. German platinum. German platinum at that time it was not metastatic, sir.
Okay.
Initially, it was not metastatic. Patient underwent simple cholecystectomy, and we have advised radical chole, but he was not willing for the immediate surgery, sir.
And you said that you gave pembro with capecitabine.
Capecitabine, oxaliplatin with pembrolizumab, sir. Yes, sir.
Okay, so I think one of the other options is nanoliposomal irinotecan as
Yes,
well.
sir.
Yeah,
Yes, sir.
that's another
Okay.
option that
Yes, sir.
you haven't used yet. You could look at that if the patient is currently progressing. And again, about the HBsAg status as well.
Yes, sir.
But starting on therapy, did you get it evaluated? Was the patient on any,
Yes, sir. Antiviral therapy he's on, sir. He's on
He's
antiviral
on.
therapy. Yes, sir.
Okay.
Yes, sir.
Because
Yes.
a couple of times you mentioned that the patient came back with jaundice.
Yes, sir. Every time it's obstructive jaundice, sir. Because of that
Okay.
cystic margin positive in the surgery specimen, he was having obstructive jaundice only. That was relieved after stenting, sir. ERCP stenting.
So fair enough. I think, from a therapeutic point of view, if the patient is still progressing, if you're looking at the next standard of care and line of therapy, would be nanoliposomal irinotecan or irinotecan-based regimens.
Yes, sir.
And all of that. And, once you've exhausted that as well and there are no further standard of care options, then you could look at, based on the NGS report, as an off-label indication, you can offer TDXT. Because it does, again, a teaching point for the postgraduates. Remember, when you have a mutation, it's the intracellular signaling pathways that you're trying to block, which is why your TKIs and ADCs are more effective. Whereas when you have expression or HER2 overexpression amplification, you're talking about the extracellular binding domain. And that's where your monoclonal antibodies come in. And that's the reason why we say that, it doesn't work well, or it doesn't work for mutations. I'm talking about monoclonal antibodies or HER2-directed monoclonal antibodies not working when you have a HER2 mutation.
This NGS is done from the post-surgical specimen or at the time of progression you have done a biopsy and then
Recurrent settings, sir. Recurrent setting, omental nodule we have sent, sir.
and IHC for head 2 also because
Yes, sir.
momentum
Same, sir. On recurrent, yes, sir. Omental nodule only we have sent.
both the same block you have done.
Yes, sir. First, initially NGS was done, and after that, I based upon the NGS report, I have sent for IHC, sir, to confirm whether we can start any anti-HER2 therapy because NGS is positive. So I just want to confirm with IHC, sir.
Fair enough.
Because your take on heterogeneity we see in the head 2 reporting IHC. So should we go and repeat the IHC test, at least IHC in the post-op specimen and the previous specimen, if it's just we see whether it's 2+ or 3+?
See, the problem again, Narayan, here is that
The momentum is heterogeneity is more. If you see in the stomach and other, there's heterogeneity is more in the momentum.
That's right. Actually, I see even in the GI tract, for that matter, we know heterogeneity, HER2 heterogeneity definitely is prevalent, right? See, but that's why we have a unique reporting system for HER2 positivity for GI malignancies, and that's actually being followed for all other. If you look at the pan-tumor O2 data again, the approval of TDXT for all other subsets, like for example, gynae everywhere, they use the gastric tumor, classification as far as reporting on HER2 is concerned. Whereas only breast, we talk about complete basolateral staining. Here we talk about basolateral staining alone. That's a difference. And also difference between the entire specimen versus the biopsy specimen, where only 5 cells or 5 clusters are good enough. And again, basolateral staining alone is good enough as far as gastric malignancies and all other subtypes are concerned. Whereas in breast, it has to be complete, diffuse, intense, more than 10%. So that's a difference. I really wouldn't want to go ahead and go back and check on the HER2 in the prior biopsy. Because again, this is not like low or ultra low here. It's not breast cancer. So we're not going to be giving someone TDXT just because it's low or ultra low. It has to be 3+, only then, and that too as a tumor agnostic therapy once the patient has progressed on all lines of therapy. I think for me, that's fair enough. Open to, deliberations.
And also, sir, generally, HER2 changes its positivity or negativity again, because generally HER2 switch we notice most of the times. So further going, suppose if I think the patient is again.
That is with breast cancer, madam, not with this gallbladder cancer.
In GI cancers, generally it won't be there, sir.
Gallbladder cancer, the switch, all these things are not really reported. No one knows exactly what will happen. But in breast cancer, you
But again,
There are chances of positive to turn negative or negative to turn positive.
so anywhere a loss is always more common than gain, man. I mean, like for you to lose your HER2 expression is always more commoner. And again, just like a hormone positivity as well. In gastric cancer, however, I can tell you the data, the Destiny Gastric 04, it required a mandate for a repeat biopsy to be done and HER2 positive on the repeat biopsy before you could give TDXT. And that was the head-on-head against ramucirumab versus plus paclitaxel versus TDXT. Showed TDXT was better. That trial mandated that a repeat biopsy showing HER2 to be positive should be done. So I think, for us, more often than not,
Here with an L2 mutation, most often there will be a missense mutation which is seen there. Would truncate the protein and then I'll not allow the protein to get expressed most often. So I think
here there is a copy number gain also, but only thing is it's not significant enough. There is a copy number gain. There is a copy number gain.
Copy number gain has not translated into a expression yet.
Exactly. That's the point to be noted here. The copy number, right? So it's not yet. It's not amplified enough, or it's not being overexpressed enough.
Because it's mutated. Whatever copy numbers have been mutated also. This truncated protein does not get expressed on the cells here.
Fair enough, but I think we're not going to act on this right away. I think the carry home is that we're not going to act on the HER2 mutation right away. But again, like we already spoke about, if you've exhausted all your standard of care, no other further options available, so look at offering it as an off-label indication. Otherwise, you have your nanoliposomal irinotecan and all those other options which you haven't tried yet, S1, TAS102, all of that. Then go on, use those molecules, and if at progression, then you could look at offering this as an option.
Any point Xantimab?
Yeah, Ashwin, go ahead. Sorry, I can't hear.
That there's one new molecule which we were trying. So the Zanidatamab.
Zanidatamab. Yeah, you're talking about zanidatamab and zenocutuzumab. Both the Zs. So
no, the first.
I think
one is a biparatropic and the other is a HER2/HER3 bispecific drug. So I mean, like you're referring to zanidatamab. That's also being looked at in the Horizon trial, looking at zanidatamab. So that's also being. I mean, like there's a trial enrolling. Even AIG Hyderabad is one of those centers enrolling that trial, but that's not for mutations. That's also for overexpression only.
Okay,
Dr. Kripa, just one question here.
Yes, sir, Arun, sir.
So, see, I understand, anti-HER2 therapy is not going to be standard of care upfront in this case. But I also wanted to know if you had done this, this GGP, would that have, and you got, I'm sure you would have got very similar or the same result in this case. Would that have made you not to use, or the treating clinician not to use immunotherapy?
Great question.
That is some
great question.
Because we know anti-HER2, HER2 is like EGFR. It's basically HER1 is EGFR, HER2 is this. So it is a negative prognosticator for immunotherapy response. So that's my question, sir.
Correct. I think, even otherwise, GB malignancies, I mean, like you see, all the trials have looked at clubbing biliary tract cancers together. But if you look at only the GB subsets, sir, the GB subsets did not actually derive the same magnitude of benefit as, like, for example, intrahepatic cholangio. So, which is why we often say the magnitude of benefit with IO in GB cancers is much lesser. And in India, the incidence of GB cancers is much higher as opposed to the Western population, where they get to see more of cholangios. So I think here definitely yes, which is why I did ask him as to why they chose to go with pembrolizumab in the first line setting. But nevertheless, the approval is across the board for all biliary tract cancers. So I think which is why they've also gone in with oxaliplatin, Capox with pembrolizumab.
I'm so sorry to interrupt, sir, but this case had some 12 cycles of IO she had received, sir. But he did well with initial 6 cycles and followed maintenance also 6 cycles we have given. Like
that's what. So we're not sure as to whether that is because of the benefit of chemotherapy.
Correct, sir. Yes, sir.
Because of the benefit of chemotherapy or immunotherapy. That's always a conundrum. But nevertheless, I think, for a GB malignancy, stage 4 GB malignancy with obstructive jaundice, this patient has actually gone on to do pretty well. It's safe to say that. because we talk about a dismal prognosis for GB cancers. And so I think fair enough, but I think Arun's point is very valid. I mean, like, had we probably, had an NGP or a CGP done upfront, we could have probably counseled the patient, telling them, see, don't expect much from IO, even though we're going to look at offering it. The magnitude of benefit for you may not be that great, as far as counseling the patient or talking to the patient and telling them about the magnitude of benefit is concerned. So I think that's definitely a very valid point.
Sir,
Yes.
can I just ask a question, sir?
Please.
Sir, since we are actually discussing about that HER2, here as such, it was a mutation and it is not overexpression, and it might not be the driver for this thing as such. No, so we can't extrapolate this HER2 and not giving an IO as such, based upon our previous discussions. Since it is not overexpressed here, and we can't use even anti-HER2, then we can't say that since HER2 is present, we can't use an IO. It might not be the driver.
Yeah.
Correct.
You're right.
You're right, Chandalekha. I'll explain
Yes.
this. For example,
Yes.
the TOPAZ study and the Keynote 966, which led to the approval of durvalumab and pembrolizumab setting, they did not look at any of these subsets. They included all the subsets, including patients who had HER2 positive disease, KRAS, BRAF, anything, BRAF, everything, all of it included. What we are trying to do is we are trying to do a subgroup analysis, or nitpicking on the data, which we all love to do. We love torturing the data to get it to confess to whatever we wanted to confess to. But nevertheless, again, the numbers are very small for us to draw any substantial, meaningful observations. But having said that, across the board, and this is again real world data that's been published from India as well, as far as GB cancers are concerned, the magnitude of benefit with IO in GB cancers as opposed to cholangiocarcinomas, be it intrahepatic, extrahepatic, when HILAR is much lesser. And that's the take home. And again, if we look at this, it's not just the HER2 mutation. Here you have a copy number gain, but it's just that it's not significant enough. So HER2 is amplified, but it's not amplified to the extent where we would say it's clinically significant. So I think all of these are like it's like, for example, when you say you have a KRAS mutation and an STK11 and KEAP1 co-mutation, we say the magnitude of benefit is likely to be lesser, right? So we say we won't give immunotherapy because of that. We would still give immunotherapy, but we would tell them, please don't expect much out of it because this is a immunologically cold tumor microenvironment. So you may not benefit as much with IU. So I think that's the sort of rationale or the reasoning that should be done. It's time we had that conversation with our patients as well before we put them or offer any drug. So as you dampen their expectations. You don't. Otherwise, they will definitely over expect. Okay, they will think, okay, my doctor has recommended IO for me, and this is going to work like magic, which may not be the case, and which more often than not is never the case.
Sorry, I don't mean to take more time, but one point I just want to make here. This HER2 is a point mutation, and this is a driver here. So, am I getting the sense that, or is it the understanding that only if it is amplified, it means it's a driver? If it's a point mutation, it's not the driver, because this is definitely the driver. If I have to look into the pathway, it is the HER2 pathway that's driving the tumor. So, is that the understanding with everyone? That's
I
just the
agree
point
with you, sir. I agree. It is actually a driver because you can see the VAF of that also.
Exactly.
Yeah, you're right, sir. Absolutely. I think it's a point mutation. It's an activating mutation. It's one of those hotspot mutations for HER2 as well.
Exactly. Yeah.
So absolutely right in that it's hotspot activating HER2 mutation. So yeah.
Is it the ATP kinase of the two?
Any point in giving any TKI, sir? Any role?
No. See, the problem is the TKIs of the HER2 are mostly like type 1 inhibitors. Type 2 inhibitors, which may act only in the native HER2 positive, native HER2 gene or HER2 protein. So you need to have a protein which is exactly going to inhibit this protein. So I don't think so. There's any specific proteins which are directed towards mutated HER2 proteins.
So I think probably to answer your question, Ashwin, HER2 exon 20 insertions, we do have molecules. I mean, like small molecule inhibitors, TKs, like zongertinib, cevabertinib, which are already approved.
The afatinib cannot be tried in this cell.
See, afatinib inhibits a native HER2. See, the problem is afatinib can inhibit a native HER2 which is not mutated. Okay.
See, again, afatinib is one molecule. It's a pan blocker. HER1, HER2,
Yes.
and
Yes.
HER4, number one, and also NRG1 also.
Yes, sir.
It has activity there as well. But in mutations per se, not a great option. I mean, like, probably if you were to say something would be better than nothing, even then I don't think it's worthwhile pushing that toxicity in Ashwin.
Yes,
So
sir.
yeah, TDXC would be a better bet if you really want to look at targeting the HER2 mutation. But that too, once, because currently it's not yet approved, which is why I said it's an off-label indication as of now.
Yes.
Can we summarize, sir, this one?
Yes, Chandrika.
So to consolidate all the points discussed, so here we had a gallbladder carcinoma patient who had a discrepancy between the CGP report where it had a mutation of the HER2 and whereas the IHC was negative. And so the discussion went on between the downstream signaling pathway and the overexpression is not there as such for this patient. So we can consider as of now, the patient is on IO and has responded partially with the IO and the chemotherapy arm. And subsequently, during progression after exhausting our usual oral chemotherapy or other drugs, maybe subsequently we can have TDXD as an option subsequently only. That's it. That's it, sir. So can we move on to the next case, sir?
Yeah, please. Go ahead.
Okay. Yes. Sir Narendran, sir.
Can you go to the next slide, please? So this
So
is
one more thing to tell, sir. We also have a postgraduate presenting for today. We'll be doing it in the last after
I'll finish it
Narendran,
right.
sir. Just for the
Okay.
academic sake, sir.
Thank you. So this is 66-year-old male who is a smoker who was diagnosed with CA lung, operated in July 2025. Pleural invasion was positive. The margin was positive. He was advised for further treatment, but the patient defaulted further treatment in July 2025. At that time, the staging was PT2 N0 adenocarcinoma. He had a history of ischemic heart disease for which stenting was done and on antiplatelets. Next slide. Now he presented 1 month before with brain mets, and on a further evaluation, he had a PET suggestive of multiple bone mets and lung mets and the brain mets. Next slide. Can you go to that? At presently, he was given whole brain RT, followed by as patient was symptomatic, whole brain RT was given, followed by he started on chemotherapy, pemetrexed, carboplatin. Can you go to that NGS report? So the NGS have not started on immunotherapy. So this NGS report suggestive of KRAS G12C missense mutation with a VAF of 9 VAF of 10, an STK11 missense mutation. And can you go to the next page also? And he has STK11 copy number loss. So STK mutation with copy number loss and KRAS mutation G12C and other mutations, a RAF copy number gain was there. And go to the above previous, yeah. And nonsense mutation in the CREP and the other mutation FBXW7 and RB1. Just wanted to know about these RB1 other mutations, significance of other mutation. And here is STK11 loss, missense mutation, and the copy number loss is there. I'm not. I'm just going with only chemotherapy and not adding immunotherapy. So on further line of progression, my plan is to go for.
I think Kripa made a comment, wild comment. See, STK11, the moment you see, you should not stop. You are stopping the immunotherapy. So you should not do it actually. You should try to give immunotherapy in that. The magnitude of benefit may be less, but you still have a benefit with immunotherapy. You cannot completely do away with immunotherapies here.
I no, just I
We'll get to that. We'll clarify that as well. But
so this is my plan. Just wanted the further
Correct.
expert plan. So
Yeah.
just wanted to.
We'll get our molecular experts Arun sir and Pushpa Singh to comment on the NGS reports, and then we will discuss on the clinical aspects.
So, regarding RB1, CREB, and FBX, is this pointing towards any other pathway? And second one is both missense mutation copy number loss is there. What is the significance of both being there? And so this is a question to the experts.
Yeah.
Clinical part, this is my opinion of only chemo, whether immunotherapy to be added. And second line, I'm planning sotorasib. So over to the experts.
We'll come to the clinical part a bit later, but I think we'll start with Arun sir and Pushpa ma'am's thoughts on the NGS reports and the pathways that are likely to be involved. Sir.
Ma'am, do you want to go first or should I go, ma'am?
As far as STK11, here there is a missense mutation as well as the copy number loss. Generally, STK11 mutation creates an immune cold environment there. So again, as said, chances of immunotherapy to work maybe it will be showing either partial response or no response at all sometimes. So partial response also chances are there. If my suggestion is, if given in combination of some chemo or targeted therapy, I think immuno will be a better choice here. So if given in combination, not as a monotherapy.
Perfect, ma'am. Sure. Valid point, ma'am. And Arun sir?
Yes, sir.
So what's the IHC PDL1 of this patient?
Narendran, do you have the PDL1 report?
I have not done, sir.
You have not done. Okay, fine, no worries. Arun sir,
initially based on the previous PDL1 we have done, it is around exactly don't remember, it's not less than 10, it's more than 10.
Okay.
10 to 20 in that range.
Fair enough. Arun sir?
Yes, sir. So just talking about the pathways here before to understand the biology of this tumor better. Now this seems to be driven by the RAS-RAF pathway, because there is a KRAS mutation and there is also a RAF amplification. So this is definitely one of the important pathways here. But what is also important is the presence of certain markers like this FBX11, STK11, CREB-B. All of these are acting they are all in the epigenetic modulators. They modify the histones and chromosomal remodeling complexes, so much so that it makes the tumor microenvironment cold. And adding insult to injury is the presence of RB1 mutation. RB1 mutation is known to cause a very significant cold tumor microenvironment. So even if the PDL1, I think you said, is about 10%, but I would be highly skeptical on the efficacy of immunotherapy in this tumor. You cannot expect more than a few months of PFS in my experience for this on immunotherapy. Of course, you're going to give it along with the chemotherapy, but the magnitude of benefit is not going to be a very long period of time.
Yeah. So I think I'll also just give my thoughts, and then I'll open it up for JC as well. So I think I think the most key thing to understand is a lot of people always think that presence of an STK11 alone means that immunotherapy will not work well. See, remember, it's in the presence of a KRAS mutation. Particularly in the presence of a KRAS mutation, there is published data to show that the magnitude of benefit with IO is not great. And also it depends on the type of KRAS as well. For example, G12C versus D, V, and 13A. So it does vary, right? Number two. And again, we have trials in the first line setting looking at combinations of, like, for example, the Sunray study looking at olmorasib plus pembrolizumab in the first line setting. Lilly is running that trial. We are actually enrolling patients on that trial as well. So this will be an ideal candidate to go on the trial, Naren, if your patient is willing to. So I think those are attractive strategies. But like was rightly pointed out, this is a KRAS G12C driven answer, and obviously co-mutations like STK11. Definitely, when you look at the NGS report and the molecular report, this tells you that it's likely to be an immunologically cold tumor. Albeit there are lots of ways in which you can circumvent it. Like, for example, give IO-IO or a double IO combination, or the IAO combination as we would call it, with chemotherapy, the checkmate 9LA design. So I think you can go ahead, because again, one of the reasons is, or that's been postulated, is the activation of the STING pathway. STING is nothing but the stimulator of interferon genes. So one way of circumventing that is by adding CTLA4 inhibition, like your Nivo-EP strategy or Durva-Tremi as well. So that's again, or with just 2 cycles of chemo, that's also an option, Naren. Or if you want to enroll the patient onto a trial, like I said, first-line trial currently ongoing, olmorasib, again, an off-state inhibitor, KRAS G12C off-state inhibitor with pembrolizumab in the first-line setting is actively enrolling as well. So again, your patient could be eligible for that.
Okay, 101 cycle, sir.
Sorry. Okay. No, actually, yeah. So actually, the trial allows you to have just had 1 cycle, and after that, no further. So just that.
Nipper is also running a trial, the same trial.
Correct.
G12.
Lot of
Nipper
centers.
is trying a lot of
Whole
centers are
brain
trying.
G2. Yeah,
Even
Prashant sir is
some cancer, Namakkal
Yeah,
center is also part of it. Varanasi, TMS is
MMC is also a part of it.
Yeah, so a lot of centers who are actually part of the Sunray. It's called the Sunray trial, looking at olmorasib plus pembrolizumab in the first-line setting, and even in the adjuvant
Whole
setting.
brain RT also. I don't know. I will just ask Prashant sir.
Yeah, so I think that's an option as well. So I think that's where we get to see the point. The reason why I brought this up is because that's ultimately where we are headed to. Earlier we thought that KRAS G12C probably only in the second-line setting. We can't act on it in the first-line setting. That is probably likely to change. And, IO plus KRAS G12C specific inhibitors, I think would probably be the future. But as of right now, you can do IO, especially a combination of IO plus IO. But given that, explain again that the magnitude of benefit is likely to be lesser. This is an immunologically cold tumor microenvironment. You're looking at ways in which you can circumvent it. So I think that would be my 2 cents as well, Naren. JC can add as well. JC.
I think you have finished it. I already wanted to tell the same points.
Perfect. So I think, key take home for me is that do not just look at the STK11 or KEAP 1 or SMARC A4, all of this as standalone. Look at it in conjunction. So, it differs whether somebody's got, like, for example, a RET or a MET or whatever, or BRAF in conjunction with the STK11 as opposed to KRAS. KRAS G12C with an STK11, yes. There is published data to that account where, it's the magnitude of benefit with IU is definitely much lesser. So that's really what I wanted to convey as well. So and look at enrolling onto trials which are actually actively enrolling for KRAS G12C inhibitors plus IU in the first-line setting.
And one other prognostic information we can get out of this is since RB1 is present in a significantly high VAF compared to others, almost 13%. Tomorrow, if the patient develops a TP53, that could possibly lead to small cell transformation.
Absolutely.
So that is something that you can be wary about.
And also there is a chance of early recurrence here, sir, due to RB1 presence.
Yeah, this is a bad tumor subtype. So RB1 mutation in cancer is not a very great news actually.
Yeah, prognostically, yes. But then again, lineage plasticity is what Arun sir is trying to tell all of us. Again, as far as P53 and RB1 loss, which can, you can have a small cell transformation. So I think that's a point as well. Like probably yes, 5 to 10% chance.
Okay, sir.
Yep, Arun.
Okay, sir. Next case we'll move on, sir.
Yeah, we'll move on. Chandrelekha, you can summarize and we'll move on. Is Chandrelekha there? Chandrelekha, are you there?
Yes, sir.
Oh, okay.
My mobile got disconnected for a few minutes. So, Narendran sir, can you please summarize?
No worries, he's presented it, so I'm sure he'll be able to summarize. It's fine.
Yes,
So,
sir.
go ahead.
Yeah.
Go ahead.
This patient, metastatic CA lung with brain mets, post whole brain RT, post 1 cycle of chemo. I'm just summarizing the previous case. So post 1 cycle of chemo with KRAS G12C mutation and other STK11 mutation, copy number loss, and RB1, which making it a cold microenvironment. So the problem we know that there's effectiveness of the immunotherapy will be less here. So either you combine with immunotherapy with the CTLA4 inhibitor, that could be a strategy, or to enroll it in the first line of trial, which is going on with KRAS inhibitor with pembrolizumab.
Perfect.
Next case, can you go down? So this is 70-year male presented with a periampullary carcinoma with normal tumor markers CA99 and CEA. So surgery was done, Whipple surgery in August 2025. Staging was histopathologically PT1N0, intestinal type. So there are no other poor risk factors. So even though PT1 intestinal type, we proceeded with S1 single agent for 6 months. And after completion of 6 months of therapy, 3 months later, the patient presented with a jaundice. And on evaluation, ultrasound suggested of multiple lesions in the liver. So further evaluation suggested of multiple lesions in the liver, no other sites involved. So we have started on chemotherapy, Gemox, 2 weekly, and we are sent for the comprehensive NGS. Can you go to the next slide? Next slide. Next slide. Next slide. Go to the NGS report. So this little bit, can you move up? Yeah. So this patient, the MSI is stable, TPF3 mutation detected, and HER2 mutation. And can you go to the next slide? There's HER2 copy number gain, which is around 11. So HER2 mutation and HER2 copy number gain was there. And previous slide. In addition to that, SMAT4 and STAC2 CTNNB1 mutation was there. So this after starting Gemox, now the patient is bilirubin is coming down. Patient is clinically responded. So I'm continuing the chemotherapy. I've sent for a HER2 new IHC. If the HER2 new IHC comes as 3+, since it's intestinal type, can we add on trastuzumab like we do it in stomach? And future later on progression after other lines of therapy, if still IHC is positive, can we give a trastuzumab deruxtecan? This is my question. And
Yeah.
so
We'll begin with Arun sir and Pushpa ma'am's thoughts on the NGS report and also the mutation, and then we'll take it forward from there. Naren. Arun sir and Pushpa ma'am.
Yes. Arun sir, would you like to take it up, sir?
Thank you. So, sir, the main driver again, you see one of the highest is with HER2 point mutation, and I guess today is a HER2 day, point mutation day. So, but interestingly, this case also had an amplification. And of course, there is TP53 and a few other mutations, one in the beta-catenin gene, the STAC2 and the SMAT4. Now, all these have only prognostic effect. There is no therapeutic value to it. But HER2 is definitely targetable. And I would not suggest trastuzumab here, although trastuzumab acts on the amplification part of it, but it is not so good or ineffective when the tumor also has a tyrosine kinase activity because of a mutation. So definitely a TDXT would be a better option in this case, purely because of the presence of the mutation.
Fair enough.
That's it.
Yeah, sure.
So, sir, here again, the KRAS, just a second. So, coming for me, again, as sir said, IHC HER2, based HER2, I don't know whether it has been checked or no. Is it necessary?
It has been sent for. It has been sent for, ma'am. That report is awaited. That's what Naren said.
Okay. I think that is one we have to look for. And as Arun sir said, TDXT would be one of the option here. And coming to other two parameters, basically the CTNNB1, what we are looking for.
Yeah, beta-catenin.
Yeah. CTNNB1 being again having an resistance in your immunotherapy again. And but if you see, there is again, just a second, can you just display that report, sir?
Yeah.
So TP53 and your generally KRAS, suppose if it's not there anyhow. So CTNNB1 is one of my concerns, whether immunotherapy if planned. And SMAD4, as Sir said, I think generally locates towards worse prognosis here. Right? So, and the STAT2, I don't think it will be having any of the therapeutic implication here. So, again, TP53 is one of my concern, and it is 220Y, 220C, which is, I think recently some drug has come for that. Is there any possibility of using that, sir, here?
This is not an exon 20 insertion, is it, ma'am? I mean, like, it's only point
No,
mutation.
no, I'm tyrosine 220C,
He's
this one,
talking
where
about the
you
P53.
Sorry.
40p54.
Yeah. So I think it's a point mutation, ma'am. I think like we discussed earlier, the latest drugs that we have in our armamentarium are for HER2 exon 20 insertions, ma'am. Like for example, the TKIs like zongertinib, sevabertinib, which we just discussed earlier, are particularly for HER2 exon 20 insertions, ma'am. So as of for point mutations, particularly HER2 as well, even if they're activating mutations like here, I mean, like TDXT again is again an off-label indication. It's not yet approved in the first line. I think the question that
So that I'm agreeing. What I'm asking is TP53 variant, this variant which is found. I don't know. I remember
you're right,
some
ma'am.
drug was
No,
discovered
you're
for
you're
that,
right.
right?
You're right about that as well, ma'am.
Yes.
P53, that drug is called Resetapopt. Resetapopt
Correct. I'm
was
not
there.
able to pronounce it.
No
Yes,
problem,
sir.
no problem. That's a tongue twister, ma'am. That is a tongue twister. But it's based on
Yeah.
phase 1 data called Pinnacle study. The response
Yes,
rates of
yes.
20%, and especially in KRAS wild type patients. If you have a KRAS mutation, it doesn't work. So, but the
Yeah.
problem is there are multiple ways in which we can look at targeting P53. One of them is the PRIMA, P53 reactivation and induction of massive apoptosis, out of which Resetapopt is a class and example. Apart from that, there is eprinetapopt and all of that. And indirect ways in which we can act on the P53 is MDM2 inhibitors like idacenatline. And again, the other ways, looking at the V1 inhibitors like adovasertib, because if they pass through the cell cycle checkpoint, the next phase they will get caught is at the by using V1 inhibitors like adovasertib. But I think that's all. None of them are approved as of yet. They're all still experimental. They're not definitely standard of care. I think the question
Coming
that
to the question is like whether to add trastuzumab to this is the question here.
if
See, you have a downstream mutation here. So which is the driver? HER2 is the driver, which is downstream. Probably the intracellular part is the driver. When you are going to use trastuzumab, which is an extracellular inhibitor of HER2.
Sorry to interrupt you. I think what Naren is trying to ask us is here the amplification, the copy number gain is around 11. And if there is HER2 IHC3 plus, can you add trastuzumab? I think that is the question that
That's the question that's the question I'm answering. Okay.
Yeah, go ahead.
Okay. So there is a mutation along with an amplification here. So if you look at the mutation which is downstream beyond the inhibition, okay. So there is if you are going to use trastuzumab, it's going to extracellularly inhibit the HER2.
Yeah,
Whereas your mutation may be downstream the pathway, which can drive the mutation irrespective of trastuzumab inhibition. So trastuzumab may not be of use here. That's what I wanted to tell.
Yeah, fair enough. I think that point we've already established. Arun sir has said the same thing, and we've discussed that earlier as well. The difference between mutations and amplification versus expression, which is why MABs work and TKIs versus ADCs as well. See, I think two ways. One way of circumventing that is to add, like for example, trastuzumab plus TKI, or give TDXT. So that way, you're making sure you're blocking both. But having said that, Naren, I think we have to wait for your IHC report. Even if your IHC is 3 plus, I mean, like for a periampullary carcinoma, even if it is intestinal subtype, we don't have the data to look at using it in the first line, like in biliary tract. So this is a periampullary, even though intestinal subtype, you might have done CDXT, which is why you're calling it intestinal subtype and not pancreatic biliary subtype. I think what's been the response to therapy so far, Naren?
Patient's bilirubin has come down, sir. So he's responding.
Yeah.
Biomarker-wise, he's responding. So
Yes.
I mean, the LFT is deranged initially. It is now coming down.
Perfect. So I think if you have somebody who's already responding to your current line of therapy, I wouldn't want to change anything about it. And obviously, we're not going to be discussing IO here, thankfully. So, this is periampullary and narrow-intestinal subtype. So we're not looking at IO as an option here at all. And we know it's a colonic tumor microenvironment. And also, again, the question of HER2 also in the first line setting, we're not going to act on it. So I think, yeah, you can reserve it as a pan-tumor agnostic indication for later lines of therapy, even if your HER2 is 3+. Use TDXT for later lines. Your patient is actually responding to your. You said gem and platinum, is that right? Or are you using platinum-based doublet?
Gemox.
Gemox, perfect. Yeah. So I think fair enough for us to continue along the same line. I mean, you've given that your patient is responding well, and next line again, like we always talk about, can be irinotecan based. And then once you're exhausted, if your IHC is 3+, act on it. Use TDXT. And then definitely you have a HER2 mutation, so it will take care of both. Other option would be to use tucatinib plus a TKI, or trastuzumab plus TKI. Off-label indications, but IHC 3+, if you're looking at the best possible response, later lines of therapy, TDXT is an option. Pan-tumor approval, you already have that. So, and that's anyone else with any other thoughts? Feel free to pitch in.
Intestinal type, you said intestinal type or pancreatobiliary type? This
intestinal. He said intestinal type.
For that, ideally, shouldn't we give 5FU base, sir? Because pancreatobiliary, I thought was for
patient already progressed after within a shorter 3 months after S1.
Oh, S1.
Yes.
Yeah, in the adjuvant setting, patient was given S1, Ashwin. So.
Okay. No problem. Sorry, I missed that part.
No worries.
Yeah, thank you.
Sure.
Okay, so to summarize, this patient, gentleman with periampullary carcinoma and intestinal subtype, who's rightly now on Gemox, with the CGP report showing ERBB2 point mutation and with the background of TP53 mutation and other mutations as well. So we were here. The point of discussion was since the ISC is awaited as of now of HER2, we were discussing the usage of trastuzumab HER2 antagonist in the subsequent lines. So the point after discussion of the points, it was discussed like trastuzumab deruxtecan can be used in subsequent line of therapy as an off-label indication as a last resort. But if the IHC is positive, we can combine trastuzumab alone or block the intracellular and the extracellular with a TKA and a trastuzumab.
So did we conclude that IHC is 3+?
No, sir. It is awaited only for only if it is 3+. We can.
If it's still 3+.
So it may not have an effect.
Yeah, trastuzumab will not work because it will be.
There's a downstream mutation.
Yes,
Trastuzumab will not work here.
So
that's what I was telling again and again.
Yeah, the
If
point of
it's 3+
discussion
also
here is because our patient had amplification with a copy number of 11 and a point mutation. So that is why we have discussed whether chemo with the trastuzumab adding would have benefit. But finally, since downstream also it's mutated, it may not have a magnitude of benefit may not be huge enough to add on. It will not help the patient.
Yeah. But deruxtecan would help. But deruxtecan subsequently would help because it is just a carrier. That's a carrier into the gene. Okay.
Yeah, deruxtecan will add, and also deruxtecan is approved as well as a pan-tumor indication.
Yeah, absolutely.
It's approved, so yeah, correct.
So after next line of progression, if the still IHC is 3+, can consider deruxtecan, or based on this mutation also and amplification also off-label, we can go for a based on pan-tumor approval, we can go for trastuzumab deruxtecan.
Yeah.
Okay, sir. Sorry, sir. So this last case is by Dr. Javahar from Royapeta. Yeah, Royapeta is second year postgraduate. Dr. Javahar, you can present your case, Dr. Javahar.
Good evening, sir.
Is this my case actually?
Yes, sir. Yes, sir.
Yeah, okay. Thank you. Go ahead.
So good evening all. Myself Javakar, second year resident from Rayapeta Hospital. We have a case, a 49 years old female, case of recurrent high-grade serous ovarian carcinoma. Initially, stage 3 at the time of diagnosis. Patient underwent primary cytoreductive surgery in 2016, followed by adjuvant 6 cycles of paclitaxel. Then patient was a disease-free interval for around 20 months. Then she had a right inguinal node recurrence, for which the patient platinum sensitive recurrence, so started on platinum-based chemo along with pemetrexed. But during the course of chemotherapy, she had a grade 3 infusion reactions to platinum therapy. Then the patient defaulted treatment for the next 6 years, around 6 years. And then she presented in November 2024 on imaging. There was fine. Patient had metastasis in liver, lung, peritoneum, and multiple non-regional nodal mets. So patient was initially started on due to the previous.
No, I'll just tell you. See, the patient had liver metastasis, lung, and peritoneum.
Yes.
The patient was again started on pemetrexed with carboplatin and bevacizumab. So patient did not add carboplatin desensitization based treatment, completed 6 cycles, and then continued pemetrexed and bevacizumab only. After that, the patient developed a solitary brain metastasis, which was excised and then followed by SRT. Okay.
Yeah. Yes, sir.
After 1.5 years, after 1.5 years of treatment, patient stopped pemetrexed and bevacizumab due to toxicity last year in April 2025.
Yes,
okay.
sir.
After that, the patient developed in 2026 January. Patient developed brain metastasis, solitary brain metastasis, which was excised and SRT was given. Okay.
Yes, sir.
Okay.
So now NGS panel was done. Can we move to the next slide, please?
So patient, go ahead, please.
Yeah, NGS panel was done. It showed a HRD positive with a genomic instability score of around 80 with the BRCA.
Go show the mutant reports, please.
Yes.
So the patient had a HRD positivity and also had a BRCA1, which is a frame shift large deletion BRCA1. Okay, which was 74.3% VAF. This NGS was done, this CGP was done in the brain biopsy specimen. Also had TP53 MAP kinase, MAP3 kinase 1 mutations.
Yes. Along with the Mike gene copy number gain and also AKT1 copy number gain also present.
So this patient also had a germline BRCA test, germline testing previously, which I could not see the reports. It was told as negative. That's it. Okay.
Yes, sir. Negative, sir.
Okay.
So,
now there was another. After this, the patient was not willing for chemotherapy, so I did send a CTC and ctDNA for looking at extra, because the patient had no extracranial disease now. Patient had only intracranial disease. So the CTCs, is the CTC ctDNA report available here?
No, sir, it was not sent to me.
No, I did send the report also. So I just tell the ctDNA did not analyze the BRCA. So ctDNA was negative. And the CTCs were 1 cell per, or it was 1 cell per milliliter, I think so, if I'm not wrong. And they did the germline BRCA also together with that. So germline BRCA by NGS was negative. MLPA was not done. So I would like to ask my molecular colleagues about what is your take on this, whether this is a tumor BRCA or is it an MLPA which is required, because this is a large deletion spanning about 400 amino acids which should have been missed by a germline NGS. I hope, hello?
Yeah.
Yes, sir.
So, yeah, Arun sir and Vrinda ma'am, I mean, like, so if you're there, ma'am, Arun sir, are you there?
I'm there, sir. Should I go first or is Pushpa ma'am?
Repeat the case presentation, sir. So for academic purpose presentation.
Yeah.
So basically, looking at here, sir, HRD score here again is 80. So HRD positivity is can be considered here, and BRCA, as sir said now, here if you look at BRCA is 74.3% of VAF. So looking at high variant allelic frequency, maybe the germline would have suggested, and that has come
This
out
is
to be
not
negative, but still
this is
MLPA
not
is
only
being
academic.
right here.
Ma'am, this is not only an academic presentation. I have just asked this is the proper presentation only. For academic reasons, but PGs also would have to some have presentation. So it is my case. I gave to some of the residents here. So see,
Yeah.
basically, what my question is, you have a BRCA mutation in the tumor now. Okay, we all know that 5 to 7% of them would be tumor BRCA. But the germline at two places. One was done in the previous hospital. I didn't see the report in full, but it was in records. It was mentioned as negative. And now, when I sent the CTC and CTDA, they automatically did germline BRCA in that by NGS only, which is BRCA negative.
Sir,
So my question is,
sorry to interrupt
is
you, sir.
uh,
Sorry to interrupt you in this because as far as CTC and ctDNA, what you are talking about, right? From one cell.
no, ma'am. See, leave away the CTC and CTDNA. When they in the CT in that testing, automatically germline BRCA is also done separately as an NGS.
Okay, got it.
So germline BRCA is done along with that panel of CTC and ctDNA. Okay. So in that germline BRCA done only by NGS is negative, and previously done almost few years ago in 2022 or 21 when the patient had recurrence last time also was negative. Germline BRCA was negative. So both of them are only by NGS, not by MLPA. This mutation is a large deletion spanning about 400 amino acids. My question to you is whether MLPA testing is mandatory. I have sent MLPA testing. So I just want to throw light on MLPA testing, how it can miss, how NGS can miss large deletions. That's what I wanted to hear.
Yeah. So,
sir, yes, sir, please.
yeah.
Professor.
Yeah, sure. So, Jesse, see, I have a bias as well because I know this patient, and
you also you know this patient. I know
the patient. I've also seen the patient, and I've asked him to meet you as well. I mean, I don't know to Dr. Anand. This is a doctor's relative as well who's treated at CMC Vellore.
Yeah. I don't want to take names here.
Yeah, no problem. I just wanted to clarify that the patients earlier also had an NGS with an MLPA done at CMC Vellore. And I had a look at that report. Unfortunately, there were no BRCA mutations picked up at that point in time.
Yeah.
So, that.
But if you go to the,
they had
look at those.
So they did that, and also JC, one more thing that's very surprising for me about the natural history and behavior of this disease. You don't expect high-grade serous ovarian carcinoma to go on for 6 years without any treatment, and the patient staying alive.
Yeah, that's what the patient did not.
How often do you see that?
Patient took treatment. Patient took 3 lines of treatment every time. Had a platinum-based doublet.
No, you said defaulted for 6 years. If you look at
No.
Okay.
It wasn't. I think they just presented wrongly.
Okay.
18 presented wrongly. I didn't want to interrupt too much of the history there.
Yeah. Sure.
18 to 21.
Yeah. So for me, the only bone of contention was, this has been behaving, clinically like a low-grade serous. I mean, like, even though, the molecular picture suggests otherwise with the presence of the BRCA, now that's been picked up as well. And also...
but the IHC is clearly a high-grade serous carcinoma. And every time the IHC was a high-grade serous carcinoma, never was a low-grade serous carcinoma.
Yeah, exactly.
And never. Yeah. See, I have seen BRCA positive patients going on for a long duration of treatment just by giving some platinums. And especially this brain metastasis I have seen in especially BRCA positive patients after a long time.
Yeah, that we understand because of the BRCA mutation. I mean, like BRCA mutant individuals. But what's interesting here is that the earlier BRCA done from CMC Vellore with an NGS with MLPA was negative. And
I have repeated the NGS and MLPA now. Let's see what I will update the reports in the next MDT. It's very interesting to see this case actually. So
It is. It is no doubt about the fact that it's an interesting case because it probably tells us that standardization across Indian labs is still a concern. I think that's a concern as well. We don't have access to centralized lab reporting as in the
Yeah, absolutely,
countries.
absolutely.
So which is why
We actually
yeah,
had this discrepancy that one lab showed BRCA positive for one of the case in stand, and we had negative in that. Basically, the technology or the algorithm what we may set in the lab may be different, sir. So many of the times that discrepancies come.
Very true, ma'am. It's just like how we always keep talking about the HRD scores, the different HRD scores. We've had that discussion multiple times.
Yeah,
Before to get into that, the GIS, GSS versus the GAS score, and the different cutoffs that are used, and the ways in which.
Yeah, when you have a BRCA positivity, obviously HRD will be positive as well. So which is a very pathogenic BRCA positivity.
Exactly, but then the problem was, it was not picked up on the earlier NGS plus MLPA, which is
That's a standardization issue. Probably a lot of labs have different things, algorithms, as you said.
Yeah, so I think that's the only thing I think, which is why when we order for a particular test from a particular lab, always make sure we look at all these parameters, the variables, how it's being done, the LOD of the assay, all of that. Make sure we look at all of that. I think that's one way. That's one probably key take home and learning point for this patient. But anyway, what have you done for the patient now, JC? What have you started the patient?
I have advised the patient to go for.
So the patient is not keen on IV drugs. Wants only oral.
Yeah, absolutely. I am convincing the patient to go for 3 cycles of carboplatin followed by PARP inhibitors.
Okay, good luck to you with that. But I think probably they don't agree. Probably
otherwise, only PARP inhibitors. That's all.
Fair enough.
I know that the indication has been withdrawn, but still.
Fair enough. Agreed, Jesse.
Sir, TP53 also being here with a high allelic frequency, I think TP53 seem to have a resistance to PARP also. So
madam. Yes, madam.
maybe we have to prefer in combination rather than giving a PARP alone.
Again, we don't combine PARP with chemotherapy. We always sequence it. Basically, we sequence chemotherapy, first platinum-based chemotherapy, followed by PARP inhibitor. I understand TP53 is at a very high allelic ratio here.
Yeah, fair enough. I think molecularly definitely looks high grade serous, and so a platinum-based doublet, re-challenging them with, provided the patient is willing to go through that.
Yeah.
Fine. But otherwise, by and far, you can, even though, like you rightly said, it's that particular indication for PARP inhibitors, monotherapy is withdrawn, currently not available. I mean, like as an indication withdrawn, you could still go ahead and offer it as an off-label indication, provided your patient is able to understand. I'm sure it is. So.
Yeah. And again, what is the choice of PARP inhibitors? I found some anecdotal reports that niraparib has slightly better CNS penetration than the other two PARP inhibitors. So I'm thinking about niraparib. What is your takes on this?
You're right. I think, you rightly said that. See, rational, I'll tell you the rational as well, as far as the difference between PARP inhibitors are concerned. I'm sure Arun sir can also chip in because it's niraparib on a lighter note. But nevertheless, I see niraparib slightly different. That's the only PARP inhibitor that's dosed based on weight, on your body weight, less than 77 kilos and less than 150,000 platelet count, where you do 200 milligrams is good enough. And also in wild type as well, that's one drug which has shown efficacy. It's got a longer half-life, better CNS penetration, better bioavailability, and also, that's why it causes more of thrombocytopenia as well. So definitely your concept of going in for niraparib here makes sense. I would have also done the same. I think if you had wanted me to choose between the PARP inhibitors as far as CNS penetration is concerned, Arun sir can chip in as well, sir.
Yeah, please.
Yes, sir. So, +1 for this niraparib aspect of things, but I also want to comment on a couple of very interesting takes on this molecular report, if I'm allowed to do that.
Please, sir. We want your input.
First, let me talk about this BRCA mutation. This is not a large deletion. This is a point mutation. What has happened is one nucleotide or maybe one or two nucleotides have got deleted, leading to frame shift effect in the protein. So my suggestion would be that you do a simple Sanger sequencing. Even if you come below the report, they should be giving exactly in the DNA level what is the nucleotide that has got deleted. So that's why there is a frame shift that is happening.
Yes, sir.
So you can do a simple Sanger, sir. Yeah, you can do a simple Sanger sequencing with any lab. And in the WBC of the patient, you should be able to, if you pick up the
I
variant,
have
it is
sent across.
germline.
I have
Yeah,
sent across NGS with MLPA. But anyway, if there's
sure.
NGS variant, I think they would do a Sangers to confirm it. I would get
They
back with
don't,
the
sir.
report.
Nobody does
No,
that, sir.
nobody
Please
does
don't.
that.
Nobody does that.
I always insist to do it. I always
Then fine,
insist.
sir.
Yeah,
I always
Don't press them the
I
labs do it. They don't.
exactly.
I always insist to do that actually
Yeah.
most
So
of the
if
time.
you have told them, that's
Sure,
fine.
sure.
Otherwise, they
Then fine.
themselves
Or
won't do
else,
it. Yeah.
yeah. So this is one thing, sir. So definitely that's something we have discussed in length here. But what as a molecular biologist I found it very interesting is the MAP3K1 loss of function. Now you generally know the MAP kinase to be a oncogene. That is, it activates the RAS-RAF pathway, right? It's downstream the RAS-RAF pathway. But here, what you see is a deletion. The particular mutation is a termination mutation at that particular amino acid position, meaning that the MAP kinase is not active here. Now, for an oncogene, why does a tumor want to evolve this mutation? Where I found it very interestingly, in breast cancers and ovarian cancers, the HBOC syndrome cancers, MAP kinase loss activates TP53 loss. And that TP53 loss is the reason for oncogenesis in MAP kinase losses that are predominantly seen in HBOC. Whereas if it's a pancreatic cancer or a GI cancer, the MAP kinase gets activation mutations or gets amplified, where you can try to target the MAP kinase pathway rather than, that's another option that is available molecularly. So this was again a learning for me. I think I'm seeing this kind of a loss of MAP kinase maybe second time in my life. Because this is a very rare occurrence and we cannot target the MAP kinase pathway. I'm surprised this discussion never came up here, but if it was any other tumor, this would be another attractive target for us.
I think the PG put a relevant question of that. I think we missed a slide.
Okay. No problems. I mean, that was a very interesting molecular wise in this tumor. I found that to be quite interesting.
See, Arun sir, just sorry for interrupting you, sir. But then, I mean, as far as low-grade serous ovarians and MAPK, your thoughts on that, and if for example, the MAPK RAS-RAF pathway being activated low-grade serous, and we have drugs that can act on it like MEK inhibitors.
Correct. So in a low grade, you do see MAP kinase pathway being activated, but in this case, it is not being activated. So to me, the molecular profile, if you don't give me the histopathology, I would say this is a high-grade tumor because there is a loss of MAP kinase, there is a BRCA, there is a TP53, and a MYC amplification. Now, MYC is again a very aggressive gene when it comes to tumors. So, to me, this looks to be an aggressive tumor. High-grade serous would be my.
IHC is the high-grade serous. IHC is high-grade serous for the past 2 times. All the occasions, it was high-grade serous.
Fair enough. Sir. I think molecularly also we're all agreeing towards the fact that it's definitely looks like a high-grade serous. But what's interesting is the BRCA mutation that's turned up now, and like Arun sir rightly said, I think it makes sense for us to go ahead and get a Sanger done.
Yeah, sure.
So any point in adding bevacizumab along with it?
No, this patient
was on
bevacizumab for a long time. Developed toxicity as well.
Gap was for more than a year.
No, had toxicity.
It is severe toxicity to bevacizumab.
Yeah. Had a lot of toxicities with Bev. So I think I agreed, Jesse. I think we have a consensus here. High-grade serous, look at getting a Sanger as well done. A chain termination method, look for the BRCA mutation, and also in the meantime, you can go ahead and offer niraparib. Given that the patient
is willing for chemotherapy, I would go for chemotherapy followed by niraparib. If not, I would go for only niraparib.
That's right. But given that the patient has already said that they're not willing, you can offer. If they're not willing,
I have convinced to some extent. We'll see.
Well, then all the best. Good luck to you with that. You convince them. So I think agreed. I think if you are able to convince them, platinum-based doublet definitely is a valid option. But she's heavily pretreated, a lot of toxicity, so you might have to watch out with the dose. But otherwise,
Yeah.
Instead of that, I mean, if we're giving carboplatin, can we re-challenge it with cisplatin, like at a lower dose? Like
cisplatin, she had a bad reaction to cisplatin.
Yeah,
Okay,
probably oxaliplatin. If have you tried Jesse? Oxali in
I have not tried oxaliplatin as of now for the patient,
Yeah.
but I don't know whether I may try only carboplatin with slow desensitization protocol.
Yeah, so I mean, like I've actually used oxaliplatin on a few of my patients, especially who've had hypersensitivity reaction with prolonged
Okay,
to
I'll
carboplatin.
try.
So not a
What is
bad.
the duration? What duration of infusion is it? 6 hours.
No, for us.
For
And
us.
we give calcium prior as well. So yeah.
Okay, fine. Let me try. Let me speak to the patient and
Sir,
try.
can we
What
add
is the partner? What partner do you go for if you are adding oxaliplatin?
So I use Gemox.
Gemox. Okay, sure.
Sir, I have a doubt, sir.
Yeah, please.
Sir, if we are adding PARP inhibitor in this patient, can we add immunotherapy along with the PARP inhibitor?
No, that is only for resistant cases.
Yeah, so correct. So platinum resistant ovarian cancer, now we have a lot of options. Check for folate receptor 1 alpha, polar 1, get a PDL1 testing done. If both negative, then then you're looking at all of these experimental things. But yes, there is a rationale to doing that. But as of right now, you have three options. One is mirvetuximab soravtansine, the other is pembrolizumab plus nab-paclitaxel plus or minus bevacizumab. Third is relacorilant plus nab-paclitaxel based on the Rosella study. So we have three options in platinum-resistant ovarian cancer, and if you cannot have, if your patient cannot access any of these, then you can do off-label indications of IO plus PARP inhibitors.
Okay, thank you.
But this case is platinum sensitive.
Yeah, it is platinum sensitive. That is just because we brought it up for discussion as far as platinum resistance was
So
concerned.
any role in considering oral topotecan, sir?
Alone as a single patient?
Oral
Platinum sensitivity is there, right? So you need to use some platinums.
Correct.
In case patient doesn't agree, then
patient does not want chemotherapy.
Any form of oral chemotherapy also they may not be very keen on. If that's the case, then PARP.
See, topotecan is not an easy thing. Okay, world topotecan has toxicities equivalent to that of IV chemotherapies.
Okay.
Yep.
Doctor, if the PG doctor has any slides, academic slides, or for a quick discussion, we can just put it up, or we'll summarize the case, sir. Dr. Jawahar, do you have any further slides for a quick discussion?
Slide was about this one, about the NGS report.
Okay.
Okay, no worries, no problem. Yeah. So we'll summarize then, Chandra.
Yes, sir. So here we had a high-grade serous ovarian carcinoma patient with a long history and metastatic disease. Right now, she was BRCA positive, and she is responding well to platinum as of now. And hence we have discussed about the BRCA and the TP53 background, and also the MAP kinase, how it works for this patient pathway, how it works in this carcinoma ovary also. And as of now, for this patient, we'll continue with the platinum-based chemotherapy, and subsequently we can use niraparib in subsequent lines. Thank you, sir. Thank you, presenters. Thank you, all the experts.